Our final presentation today is by Dr. Brian Morse, who's a diagnostic imaging specialist, and he's going to talk about PRRT and I think some diagnostic imaging. So without further ado, let's welcome Dr. Brian Morse.
All right, well, before I get started, I just wanted to say thank you to Bob, everybody at NCAN for all their hard work putting this together. I know it's something of real benefit, and there's a lot of work they put in behind the scenes to pull something like this off, and it's really a tremendous achievement on their part. And I also just wanted to say I've given a lot of talks before, but it's always to physician groups or doctors or people involved with healthcare somehow. So this is actually one of the first talks I've given just to a group targeted at patients. So it was a struggle to me to figure out exactly I had the topic of the talk, but I was a struggle to figure out the level of difficulty or avoiding too much medical jargon. So, and yet, I'm sure people at this point, you're familiar with the disease process, so I also didn't want to be too simplistic. So I hope I hit the nail on the head, but, I would welcome any kind of feedback anybody had. If you give that to the people at NCAN or to myself sometime during the meeting, just in case I ever have this opportunity again, I'd like to know what you'd be interested in as a patient, or if you thought something was way too complex or way too simple. I am a radiologist at Moffitt Cancer Center in Tampa, Florida, and today we're going to be talking about peptide receptor radionuclide therapy, or probably I'll just call it PRRT, so I don't burn my tongue out throughout the talk of the talk, and a little bit about some of these other diagnostic tests you get. So, obviously, modern day medical care, there's a ton of these radiology tests, so X-rays, ultrasounds, MRIs. And then some specific, what they call nuclear medicine tests that you get for neuroendocrine tumors. So we're going to talk about that so you'll be a little bit familiar with that and see the benefits of these technologies. And so as we talk about today, neuroendocrine tumors, they arise from the neuroendocrine system. And what that means is they can involve these cells are spread all throughout your body. So a lot of these neuroendocrine tumors are in the GI tract, so, small bowel or pancreas, but they can arise in many, many different organ systems. And kind of a hallmark, what people have referred to today, is this is a very, very complicated disease process to treat and to diagnose, and part of that is because of the heterogeneity. And what I mean by that is, you can have primary tumors can arise in multiple different sites. The characteristics can change based on the site of origin. The grade of the tumor, which somebody else had talked about today, they can be fairly indolent or benign, things that don't cause much of a problem, to very, very aggressive tumors that can kill you in a very short time period if they're not treated. And the level of hormone secretion, they can be what's called functional or non-functional. So a functional tumor would, you'd have symptoms from these excess hormones secreted by the tumor beyond what your body would normally produce. And most importantly to what I'm going to talk about today is if the tumors have receptors for somatostatin on them. And the other Dr. Morse referred to somatostatin earlier this morning. It's a hormone that's found in your body. It's a naturally secreted hormone in your body. And in order for that to act on cells, there has to be a receptor there. And so neuroendocrine tumors, they can have a very, very high level of these, or high level of expression. Sometimes you hear me say that during the talk. What that just means is there's a lot of them on the cell surface, or there may be a low level, or they could be even absent. And we've already talked about this a little bit. So somatostatin, it's a peptide or protein hormone. It's secreted normally by your body. It's an inhibitory hormone. So what it does, it slows down the activity of the GI tract. It reduces the contractility or the emptying of your gallbladder. It has an inhibitory effect on multiple hormones, so growth hormone or these other hormones that are associated with your GI tract, like insulin. And if you look at this little diagrammatic picture here, so if somatostatin is this little purple molecule, in order for this to act on a cell and exert its effect, it has to have a receptor, and that's what these little pink bars are. So in order for somatostatin to exert its effect on a cell, whether that's a normal cell or a tumor cell, it has to have or express these receptors on its surface. And there's 5 different subtypes of these receptors, 1 through 5, and each one of these has a slightly different effect on the cell when it's bound by somatostatin. So somatostatin receptors are found throughout the body, right? Because somatostatin there's multiple different organ systems it can affect. In order for it to affect these things, it has to have this receptor on their surface. And that's a normal process, right? So parts of the GI tract or inflammatory immune cells in your body, they've got this receptor on them, so somatostatin can bind them and exert this inhibitory effect. The reason why this is relevant to us is because neuroendocrine tumors, and in particular gastrointestinal neuroendocrine tumors, have a very high density of these receptors on their surface. and particularly for GI tumors, the subtype 2 receptor. So, somatostatin, people have talked about this earlier. Somatostatin was, it was originally, people were interested in it to treat acromegaly, which is excess growth hormone. But if you take the somatostatin molecule from somebody's body, you could isolate that. It's not useful as a medicine because the duration of action is very, very fast. If you gave it to somebody, it'd be gone almost immediately, and you can get some rebound hypersecretion of the hormones you're trying to decrease. So it's not useful. And people looked into finding what they called an analog. So basically a drug that was kind of like somatostatin, but had a much, much longer half-life. So it's a little bit different from somatostatin, but your body can't really tell the difference. And if we go back to this diagram, so now what you got is an analog, which is not like, it's not the native somatostatin from your body, but it's an analog. It'll hit these receptors, go into the cell, and exert that inhibitory effect, just like somatostatin. And now why this is important for neuroendocrine tumors is because if you have this molecule that can mimic somatostatin, and it can specifically target the tumor cells, because the tumor cells express the receptor, so these analogs can bind to the tumor receptor and exert this inhibitory effect. So that's why octreotide, one of these first analogs, and they've got multiple different analogs now, that's why they're useful, because they can bind to the cell, they control the hypersecretion of hormones that you see with this, because they take advantage of that inhibitory effect that somatostatin does. And it works because it specifically targets the tumor cells. So this is a really neat treatment, right? When you think about, a lot of these, some chemotherapy agents, you give them the patients and they affect cancers, but they don't specifically target that cancer. So you get multiple side effects and things like that. Even though octreotide was invented a long time ago, it was sort of this first advent of what they call molecular medicine, so specifically targeting that drug to the tumor cells. And that raises the question, if you have a drug that can target the tumor cells, could you use that targeting of that compound to make pictures of the cells, to diagnose them and stage the patients? And the answer is yes, you can, and that's where the octreoscan came from. So what you do, or what they did, was they took that somatostatin analog and they bound a radionuclide to that. And what a radionuclide is, if you think back to, high school chemistry, think of the periodic table of the elements, everybody knows things like, and maybe Breaking Bad makes them more familiar, right? They have that at that opening monologue, they show the periodic table. So you've got sodium, chloride, gold, silver. We're all aware of these things. These are elements. Well, in medicine and with neuroendocrine tumors, we use radionuclides like yttrium or lutetium or indium. So these are things that, you're not as familiar with, but what's special about these elements is that they're radioactive. And what that means is that they give off levels of radioactivity. And you can detect that radioactivity and use it to make pictures. And that's what an octreoscan is. So you bind this radioactive element to the somatostatin analog, give that to the patient, it goes into the body, it goes to the sites of the tumor, and then you can make pictures based on that small level of radioactivity. This is a kind of a conventional CT scan. By now everybody kind of knows what these look like. This is a patient with a small bowel carcinoid or a small bowel neuroendocrine tumor, and this is a very, very common site of metastatic disease. You get this big lymph node mass in the mesentery. So this is kind of easy. You don't need an octreoscan to find this. You should be able to see this without an octreoscan. What the octreoscan does here is this is a CT image that's the nuclear medicine data is this stuff in color, and the CT image is just this kind of same technology. You can kind of fuse the information so that you can localize where this nuclear medicine, where the activity of the somatostatin receptors are. And so you can see this mass is very, very bright. And what that means is that there's a very, very high density of the receptors on this cell. So this part of the tumor would be treated very, very well by a somatostatin analog. You could bind to that and exert that inhibitory effect. But an important point to remember, the receptors are found throughout the body, right? So you can see there's some activity in the colon, and that's normal because you don't have somatostatin receptors only on tumors or other sites. There's activity in the kidneys because the compound is excreted through the kidneys, and that's going to be relevant when we get to talking about PRRT. This is another case. Now you can see maybe the diagnostic utility of an octreoscan, so why it might help you. So even, very, very advanced CT and MRIs, this is a metastasis in the liver. So the tumor has gone to the liver. But you can see if this were just a little bit smaller, it'd be very, very hard to pick out from just normal vessels. And also, if I have to tell you, if the timing of this exam were a little bit different, if it required a few seconds either way, earlier or later than when this was acquired, you might not see this at all. And that can be why we have trouble, even with modern medical imaging, that can pick up things that are a couple millimeters in size, and this incredible medical imaging we can do with CT and MR, you can still miss tumors with neuroendocrine tumors. And you see the advantage of the octreoscan. Not only, now you can see some normal background activity, and you just have to be aware of where the background activity is. And then you can see this is abnormal. There's background activity in the liver, but this is too much, and it corresponds with this lesion. And it's helpful because if the CT scan had some of those limitations we talked about, you'd still be able to find the metastasis, and then you would also know, is it expressing the somatostatin receptors? So that begs the question: if you have a medicine that can specifically target the tumor to treat it, yeah, and if you put a radioactive molecule on that medicine and it can help you make pictures of the tumor, could you put enough radioactivity on that medicine to kill the tumor? And the answer is yes. And that's where this came from, peptide receptor radionuclide therapy. And it's a big name, but now you understand where the name comes from, right? Because peptide or protein, that's referring to the somatostatin analog. Receptor, because we go after those somatostatin, the receptors have to be on the surface of the tumor in order to treat it. The radionuclide refers to that little element that we stick on there that gives off the radioactivity and the therapy. So that's where this big name comes from. And this was first done in the 1990s. A lot of this work was done in, pretty much, I guess all this work is really done in Europe, where it's actually more in widespread clinical use. And they saw that, they were able to do this. They were able to take the somatostatin analog and put a radionuclide on there that emits a higher level of radioactivity. So it's not just this low level to make pictures. It's a very high level to kill the tumor. And it was successful. They had symptom relief, tumor shrinkage, patients had improved survival. But initially they saw that, because not all of this goes just to the tumor, there were side effects. And what they saw initially was bone marrow toxicity. So you can call it, your bone marrow is responsible for, producing red blood cells, white blood cells, platelets, things that are essential for survival. And what can happen is you can induce a cancer of the bone marrow, leukemia, or you can kill the bone marrow to where it can't make these essential things. So either one of which obviously very, very bad. So there are multiple different variables that they started playing with to perfect the therapy, to improve its efficacy, and to decrease the side effects. And there's all kinds of different things you can work on. You can change up the analog. You can change the radionuclide that you're giving. They had to figure out how much radioactive dose can you give to limit side effects but still kill tumor. Do you give it all at once? If you break it up, how do you break it up? A lot of different variables to work out. But over time, they found they were able to achieve better and better anti-tumor effects with less side effects. But still, with modern PRRT, our main areas of concern for side effects are the bone marrow, so not inducing a cancer or suppressing the bone marrow where it can function, and the kidneys, because these agents are excreted through the kidneys, so all that radioactivity, when the kidneys essentially concentrates things and then excretes them from the body, this agent that you inject will be concentrated by the kidneys to be excreted from the body, so the kidneys are going to get a high dose of radiation. So you have to be very, very careful how you calculate that dose that they're getting. And the concern with the kidneys is not inducing a cancer in them, but you can actually damage function to the point where kidneys are not working. And if it's severe enough, you would have to go on dialysis. So it's very, very important to take that into account. So why is this very exciting time for this in America right now? Well, like I said, this has been done. A lot of this research was done in Europe. It's used in Europe. And it's never been FDA approved because there was a lack of strong enough evidence. Well, now, just recently, someone else alluded to this. There was a clinical trial that's still ongoing called NETTER-1. Everything in medicine has to have some kind of acronym. I guess they borrowed this from the military. So it has to. My dad was career military, so he used to joke about that. But NETTER-1 is the acronym. And so this is some of the strongest, highest level evidence you can get. It's the first phase 3 randomized multi-institutional clinical trial PRRT. And the way this was set up is they took patients who had well-differentiated mid-gut neuroendocrine tumors that their cancers had gotten worse when they're on the first-line therapy with a somatostatin analog. They broke them up into 2 groups. One group got the PRRT with the specific compound is called lutetium dotatate, and lutetium is the radionuclide. And the other group got this higher dose octreotide. And what they found, we're not going to delve into the specific numbers and a lot of the medical jargon because I think that can get a little confusing, but they found incredible results. And some of the preliminary data was released. The study is still ongoing, but they found much longer progression-free survival and higher response rates. So basically, response rates of tumor, which were far greater than what they expected and far greater than this other therapy, which was what they would be offered without PRRT. And they found a very low level of side effects. So as of the time when they released the results, there were no renal issues, and there was significant bone marrow toxicity in less than 10% of patients. So very, very effective treatment with a minimal side effect profile. And why this is important is that, when you have a neuroendocrine tumor, if you fail the first-line therapy, these somatostatin analogs, in a lot of cases, you've heard today about all these clinical trials and all these other things going on, but there's not really a well-defined second-line therapy for a lot of these tumors. And it's very exciting to have this available as an option that's proven to have very, very good anti-tumor activity, very good at, suppressing symptoms, treating tumors, shrinking tumors. How this is going to play out in the United States now that this is released and this is coming out and going to be available at more and more centers is something I think that's going to be an area of, it's going to be, since, NETTER-1 was under very specific conditions, So, people are going to want to apply that outside those conditions, which is going to result in a little heterogeneity of how people practice. But essentially the bottom line is that this is a very, very promising new tool that people are going to have to their armamentarium to treat neuroendocrine tumors after they fail first-line therapy. And one thing to keep in mind is that with all these things I've talked about, so for a somatostatin analog to work, for you to be able to image the tumor with an Octria scan, and for you to be able to kill the tumor with PRRT, it has to express those somatostatin receptors on its cell surface, and not all neuroendocrine tumors do that. So, that can be a problem, and specifically, actually kind of some of the more well-differentiated tumors, which are not as aggressive, are the ones that tend to express the highest level of this receptor. So unfortunately, some of the tumors that are more dedifferentiated and can be a lot more aggressive don't express the receptor, and therefore are not these things are not as effective with them. So that's one caveat to remember. If you were looking into this, if you were getting these scans or looking into these options, and your doctor said you're not a candidate, why not? But that would probably be that's going to be one of the main considerations, because there are tumors that this will not work at all. And so we've talked about, now to delve back into that, so NETTER1 and PRRT and the expanded use in America is going to be very, very exciting, and it's really going to be, I think, a positive impact on the treatment of neuroendocrine tumor patients in America. But and that's a relatively recent, the preliminary results of this trial were just released. But another thing that's on the scene now is improved diagnostic capabilities of these tumors. So another thing they've been doing in Europe for a long time is Octria scan is a good test, but it can be somewhat insensitive, meaning it can have a hard time finding all the sites of the tumor, or very, very small, particularly when you have metastatic disease, but it's very small. And you still want to know about those because even though they're small, they're very, very important. They can change your management. So there was a need to find a test that was more sensitive than an Octria scan. And this is what you may have heard about this, but the NetSpot or this gallium-68 dotatate PET-CT. And what this is, so we kind of know about this now because we talked about this concept of having a target, which is a receptor on the surface of the tumor. And basically the way you target that is you take the peptide or the somatostatin analog and you link it up to a radionuclide, which gives off this radiation. So you want to get this radiation on the tumor cells so you can make pictures, and you change up the peptide, you change up the radionuclide. It allows the use of PET-CT instead of this other technology called SPECT-CT. And this is it's a great technology because through this, basically what you can do with this, it's far, far more sensitive than Octria scan, yet you actually can accomplish it with a lower radiation dose than you would do with an Octria scan. So it's really a win-win situation. And multiple studies at centers in America have shown that even with the most advanced diagnostic capabilities we have available today, when you finally make the diagnosis of a neuroendocrine tumor, you can, even today with all the advanced medical imaging, all the advanced, science we have, sometimes a patient, you find a patient, they have metastatic neuroendocrine tumor, but you don't know the primary tumor. Or you're working up this case and you think they have a neuroendocrine tumor, but you just can't prove it. Or there's a known tumor and you're trying to find all the sites of disease for that initial workup, because that is going to tell you what your therapy is going to be. Are you going to give medical therapy? Are you going to do surgery? If you do surgery, it would be staged surgery. You've seen how complex the treatment decisions can be in this tumor type. So in order to get the best therapy and most appropriate therapy, you need to get that upfront staging as accurate as you can. And this is where this is really kind of revolutionary, because multiple studies have shown if you take a patient, you do our most advanced imaging that you possibly can, most advanced workup, then you do a gallium PET-CT, it changes treatment plans in a significant number of those patients. So you'll take patients where maybe they thought they were going to be able to have surgery, but then when you do the gallium PET-CT, you say, oh my gosh, they've got so much tumor, so much metastatic disease that surgery would be of no benefit. It would basically, there'd still be so much tumor left after the surgery, it's not worthwhile doing that. So then you pursue medical therapy. Or if you're going to do a surgery, you do this and you find, oh my goodness, Dr. Ian Eddy had referred to this earlier in the day, where, medical imaging, even great medical imaging, underestimates tumor burden. So you're going to do surgery, or you have a surgery plan, you do the PET-CT, and you see that the disease is much more extensive. You could still resect it, but you got to know about these things during the treatment plan. So this is really, there are some things in medicine that come about, and they seem really neat, and the science is really neat, but they don't have an actual impact on patient management. And multiple studies have shown that this technology changes the way people are managed. So, and this is just now FDA approved, and is going to be working become more and more widespread in America. And here's an example of how that happens. So here's a patient that, suspected pancreatic neuroendocrine tumor. You do the CT scan, the most advanced CT scan you can do, and there's nothing. You see nothing, and it's very, no one is happy with this result, right? Because the patient's not happy, they're having symptoms, the doctors aren't happy, they think they have a pancreatic neuroendocrine tumor, they can't find it, they can't determine how to treat it. You do the gallium PET CT in the same patient at the same level, and what you can see here is very clearly they've got two pancreatic tumors, and we had one site of metastatic disease in the liver, and now you know where all the disease is. You went from not even knowing where the primary tumor was to knowing exactly where the primary tumor is, how many primary tumors there are, and where the sites of metastatic disease are. And that's how you can, come up with an accurate treatment plan that's going to positively impact the outcome of that patient. Here's another case. This is with MRI, which, depending on the indication you're talking about, but in most indications, MRI is going to be far more sensitive than CT. So even with, with your state-of-the-art CT, state-of-the-art MRI should be even better. This person was another suspected pancreatic neuroendocrine tumor. These areas of where the tumor are actually circled, and you can see, we see no abnormality that sticks out from the pancreas on here, on these images. Yet when you do the gallium PET CT, you can see quite clearly 3 pancreatic tumors that our most advanced medical imaging could not pick up. So, if you, and that's why this can change management, because, if you want to resect these pancreatic tumors, you want to know if there's more than one, because that's totally going to change your surgery. And pancreatic surgery, regardless of who's doing it, no matter how skilled they are, is a big deal. So, these are revolutionary. Revolutionary might be too strong, but I mean, PRRT and gallium-68 is going to result in much better staging of patients with the gallium-68 PET CT, and another exciting avenue of therapy with PRRT. And actually, one of the, these are both made by the same company, and they have a representative here today, the AAA. And so he could, if you're interested in if that's available in your area, or if it's coming to your area, or finding out more about who in your area are doing these things, that would be a great resource for that, because even I'm not aware of everywhere. It's expanding rapidly, but it needs to expand rapidly, more rapidly, particularly gallium-68 PET CT. Just want to check to see how I'm doing on time here. Okay, good. Now, so these are some of the nuclear medicine things that are specific to neuroendocrine tumors, but as a patient involved in our medical system, you're going to be getting things like X-ray, CT scans, MRIs. I just want to touch a little bit on that, and then give you a little bit of frame of reference, and then talk a little bit about radiation dose, because I think that's something of interest to people when they're, in getting all these scans and all these other things, some kind of frame of reference and a little bit of information about that. So radionuclides, what we talked about, are molecules we inject in the body. They give off radiation, and we can detect where they are in the body based on that radiation and where the tumor is. X-rays, everybody knows what a chest X-ray is, right? You stand in front, everybody's probably had one, or an X-ray of your arm or something. Basically what that is, the radiation is not injected into you, the radiation is shot at you. So you shoot the radiation, if I get an X-ray of my arm, I put my arm up, there's a detector back here, the radiation source is here, X-rays are shot through my arm, they hit the receptor, and basically how the X-rays are blocked by the density of the various tissues in my arm makes the image. A CT scan is essentially the same concept, but it's, there's multiple detectors, multiple radiation sources and detectors on a big cone. It spins around you and you move through the tube. So it's the same concept, except you're scanning a volume and making a volumetric picture. But both of them involve the same thing, X-rays or ionizing radiation to make pictures of your body. Whereas an MRI uses magnetic fields and radio waves to make images, so that doesn't expose you to any kind of radiation, any kind of ionizing radiation. Or when I say ionizing radiation, what that means is that there's a potential that could damage your DNA. So radiographs are quick, they're widely available, they're quick, fast, easy to do. CT scan is also widely available now. And the difference between those two is that radiographs are a fraction of the radiation dose of CT scans. So if I'm exposing you to a higher radiation dose, am I kind of getting my money's worth? And the answer is yes. CT scans provide so much more information versus radiographs, and it's why much of our medical imaging now has moved from radiographs to CT scans, whether you're talking about trauma or emergency medicine or cancer imaging in particular. And there's no way we could do what we do with radiographs and cancer imaging. And MRI is even more sensitive than CT. The problem with MRI, depending on the exact application, and the reason why MRI is probably not even more widespread is because scanners are extremely expensive, so which limits their distribution, and they're also more difficult to operate. They're more difficult to properly perform the exam and interpret the exam. So the bulk of our medical imaging, the bulk of things you're gonna encounter that are not nuclear medicine imaging or CT scans. And when I talk about more information, here's an example of that. So this is a real patient in the hospital, not a neuroendocrine tumor patient, but suspected bowel obstruction. And this is a radiograph of their abdomen that was actually obtained. And If you're looking at this and you think it doesn't look that good, you're right. But this is what you run into because patients are sick. They can't leave their hospital bed. You have to get radiographs that are done portably. If the patient is obese, which this patient, was somewhat obese, it can limit what you're looking at. You can kind of see there's a feeding tube. We can kind of see loops of bowel. They don't look too dilated, but we don't know exactly what's going on. This exact same patient, CT scan. Now this is one image acquired with a radiograph. CT scan is in hundreds, usually it's sometimes thousands of images you would scroll through. I selected one of these images. You can look at and this is in the exact same plane that we see this, and look at the information. I could talk for probably my whole talk about the information we get from the CT scan versus this. So we see the vessels. The vessels are patent. There's no blood clots. There's normal vascular supply to the organs. The kidneys are not obstructed. The bile ducts are not obstructed. The pancreatic duct is not obstructed. You can see the exact position of any feeding tubes. You can see this is some fluid or ascites in the abdomen. There's extensive edema of the subcutaneous soft tissues. They've got a pericardial. It just goes on and on and on. So why do we use CT scan instead of radiographs? The amount of information you get is there's a much more information you get, and multiple studies have shown that even though CT scans expose our population to medical radiation, we gain tremendous benefits in all areas of medical care from this technology. So whether you're talking about emergency medicine, there was a time where if they thought you had appendicitis, the way they verified that was they cut you open. And now, if they think you have appendicitis, they do a CT scan. Many times you find patients don't have appendicitis. So an operation would have been of no benefit, and it could have harmed you because you had another process going on besides appendicitis, but now you've got a big slice in your abdomen. So there's multiple studies, emergency medicine, trauma imaging, all these things about why we're switching to CT scans. But this does result in a radiation dose to our population. I'm going to address that right after this. So specific imaging considerations for neuroendocrine tumors that you're going to run into, more and more the baseline staging, baseline imaging to figure out where all the sites of disease are is going to move to gallium-68 PET-CT. And this is going to be, I think, is going to have a tremendous positive impact on how you're going to be, patients are treated, because it gives you the best treatment plan because you know where all the sites of disease are, even over the most advanced medical imaging we have right now. And then, when you get CT scans, it's going to focus on the area of concern. And that's why gallium-68, the PET-CT can provide kind of whole body imaging to determine where all your sites of disease are, so that when you get follow-up, if you have a neuroendocrine tumor or what they call bronchial carcinoid in your lungs, then you're going to get scanned in the chest. Whereas if you had a neuroendocrine tumor in your small bowel, you'll get scans in the abdomen and pelvis, but you might not get CT scans of the chest. So, the CT imaging needs to focus on the area of concern. Liver imaging, when you do have abdominal imaging and initially to detect metastatic disease, or if you have mets in your liver, many times that's going to be multiple passes through the liver. And the reason why we do that is because neuroendocrine tumors, the way they change their appearance with IV contrast over time, helps us characterize them, helps us detect them initially, and it helps us characterize how they change or respond to therapy. So that results in a higher radiation dose, which, even in patients with cancer, you want to be aware of that. But that's why that is kind of the standard of therapy, or standard of medical imaging with neuroendocrine tumors, is that they scan multiple times through your abdomen. And when you do MRI, they also do multiple passes. That's kind of, but there's no cost to that because there's no radiation exposure. So this is what I mean about, this is a CT scan without IV contrast, and you can see it's very, very hard to see things in the liver. Here we've given the IV contrast, and we acquired 2 CT scans, one through the abdomen at different time points. Here are the metastases, and you can see if you just acquired this CT scan at this time point, you'd see the mets, but they'd be a little hard to pick out. There might be smaller ones that would be hard to pick out from the vessels, whereas over here they stand out much more clearly. And so also, if you don't have these time points, figuring out how you're responding to therapy, if it's a medical therapy or that is supposed to decrease the enhancement of the drug, like an anti-angiogenic thing somebody had mentioned earlier today, or if they got one of these therapies where they, they talked about with the interventional radiologist putting, medicine or cutting off the blood supply to the tumor, then you've got to see decreased enhancement. So this is why when you get scanned, if you have metastatic disease in your liver, it's not just going to be one. It's frequently it's going to be more than one. And hopefully your doctor should be, if they're experienced with neuroendocrine tumor, should be aware of that and realize that that's, important to do that. This is another example of a patient with pancreatic neuroendocrine tumor, metastatic liver, and just the importance of this multi-phase imaging. So very, very extensive metastatic disease burden in the liver. And you can see, if you only acquired one time point, an early time point, you can see the mets But, a lot of times for measuring response therapy, and particularly for clinical trials, the actual measurements of the tumor are very, very important and can determine, even though, and sometimes that's not an entirely 100% legitimate way of knowing what's going on, it's still the most objective way. And so you can see if you're going to measure tumors, it's a lot easier to measure things over here than it is over here. If two or three different people measure tumors over here, they're going to get very similar measurements, whereas over here, you're going to get different measurements. So neuroendocrine tumors, multi-phase imaging, that's when that happens to you, even though it's a higher radiation dose, that's why it happens. And this is an example of sensitivity of MRI, different sequences. You can see, even with MRI, some sequences are more sensitive than other ones. Now, radiation dose, this is kind of a complicated topic, and there's a lot to fit in this talk, but I'd like to give you just some kind of a little bit of a baseline here for some frame of reference when you're thinking about this. So the most relevant thing for when you're talking about medical imaging doses is something called effective dose. And the reason why that there are other things you can measure, but effective dose kind of takes into account the different tissues that are being irradiated. Because when I talk about a radiation dose to your body, that's kind of a made-up concept. And the reason why that is because different organs of your body have a different level of radiosensitivity. And when I'm talking about medical imaging, I'm talking about potentially inducing cancer. So, when I think people think about radioactivity, they think about radiation burns or dying from radiation, unless you're, have somebody who's sick or involved in healthcare and getting this medical imaging, your exposure to radiation is thinking about nuclear bombs or, Fukushima or Chernobyl. So medical imaging, the radiation doses are much, 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 much smaller. And we're not talking about things that would have any kind of acute effect, but something that can induce radiation-induced cancer. And so, the sensitivity of your organs, if I got an X-ray of my arm, what's being exposed to radiation is my skin, my bones, my blood vessels, my muscles. I could get a very high dose of radiation in my arm, nothing's ever going to happen because those tissues are not very sensitive to radiation. Whereas if I got that same dose to my chest, to the lungs, or to the thyroid, or of my abdomen, to my bowel, those organs are much more sensitive, and there's a much higher chance of inducing a radiation-induced malignancy if they were exposed to the same level of radiation. So when I talk about a radiation dose, it's a very artificial concept because that doesn't take into account the radiosensitivity of all the different organs. And, if I got an arm X-ray, there's essentially no dose to these other radiosensitive areas. So even though I got this radiation dose, I don't really have a chance the chance of getting cancer is very, very low. And these are measured in units that are kind of foreign. They're called sieverts or rem. And the reason why these are a convenient way to express this is that this gives you kind of an idea that you can wrap your mind around. So your environmental exposure, what we're all exposed to just from living in our environment, is about 3 millisieverts. So there's cosmic radiation that actually comes through our atmosphere to space, from space, and irradiates us. It's a very, very, very small dose, but it is measurable. There are radioactive elements in our food and our water and our soil that we're exposed to that result in this dose. And actually, your radiation dose is higher if you live at sea level versus living in Colorado or Denver. You have a higher radiation dose just from that cosmic level of exposure. It's very, very small, and the significance of that is essentially nothing, but it is measurable. And so you can kind of, I don't know if this is that helpful to me, but some people really like this. That you can compare that environmental exposure to a diagnostic test to give an idea. So a chest X-ray is going to be like 0.1 millisieverts. An abdomen pelvis CT scan would be like 10. An arteria scan might be, and these are going to vary from site to site, institution to institution. And when I say PET CT, that's with FDG. So that would be something like you'd use for lymphoma or colon cancer, not a gallium-68 PET CT. The radiation dose of that is actually much lower than this kind of PET CT. And just to give you an idea, so you can see these are medical doses. And if you talk about the radiation dose that might be familiar with from, just our daily lives, nuclear meltdowns, radiation in bombs, things like that. There's something called an LD50 or a lethal dose 50, where if you're exposed to this, 50% of people will die. So this is what you would see at one of those, a nuclear bomb or nuclear reactor meltdown. You get 4,500 millisieverts. So you can see there's a far, far difference that we're talking about with we're not talking about your skin getting red or you actually having any kind of acute side effect from radiation. This would be something, that just this theoretical risk of inducing a cancer. And so we've talked a little bit about how our estimates of risk are imperfect. And that's because radiation dose is kind of an artificial concept when you talk about that over the whole body. And it gets really, really complicated, but an expert panel convened to this of experts and physicists and other things, and they came up that, from an exposure of 10 millisieverts, 1 out of 1,000 patients are going to get cancer from that exposure. And now when you see that, you're kind of like, well, whoa, wait a second. And that CDC, that's 10 millisieverts right there. So you're increasing my risk of cancer? But when that same expert panel, to give you a frame of reference, talked about using their same risk calculators, your risk of getting cancer is 420 out of 1,000. So that means if you get that abdomen pelvis CT scan, your risk just went up from 420 to 421. It's measurable, it's there, but it's fairly insignificant. And particularly when you talk about that number, 420 out of 1,000, things like diet, exercise, exposure to alcohol, tobacco, sleep, etc. You modify any one of those in a positive way, and we all know these things, then you're talking about a tremendous difference in your cancer risk. People get worked up about getting one CT scan, and they're smoking. Right? I mean, these are legitimate things. I mean, I've taught, these are things that come up. And there's another thing that helps you kind of put it in perspective. The Insurance Information Institute, the lifetime risk of accidental death, right? So to give comparable statistics. So dying in a motor vehicle accident, 1 in 113. And I did a radiology residency in Dallas, Texas at Parkland Hospital. It's one of the busiest trauma centers in the country, and I got anxiety attacks driving because we would work 24, 36-hour shifts. This is back when there were less regulations on this, and essentially it was 24 hours of watching people die from car crashes. 16-year-olds and old people, young people, and I don't know if my colleagues ever got it affected them, but to me I almost was having like PTSD from watching so many people die from car crashes, and yet. You would think nothing, absolutely nothing, about not buckling your seatbelt, texting, answering a phone call while you're driving. But people get really worked up about a CT scan. And, well, it's true. I mean, but why is that? Because driving is familiar, right? I mean, I'm the same way with flying on a plane. I kind of have a mild phobia of flying. But I think nothing about driving my car. But the risk of death between those two activities is tremendously different, and it's not logical, but that's kind of the emotional side of things. But some other numbers. So this is in America, dying by assault by firearm, 1 in 358. But people have guns around their house. You don't think anything about it. And even dying by fire or smoke inhalation. So I'm kind of going on my time here. I'm sorry about that. But I don't want to blow it off totally, because it could be a concern, because patients with neuroendocrine tumors, you might be getting multiple scans. One thing to think about is that, this is a concern for younger patients, and to be honest, patients who have a longer life expectancy, because these malignancies would never even come about for 10, 20, or 30 years down the road. So when you're talking about, an 80-year-old patient getting CT scans and maybe getting multiple CT scans, it's fruitless, okay? Because unless that guy is thinking he's going to live to 110, very, very positive he's going to live to 110, it's not going to happen. But it could be a consideration, especially with younger people, or if you've had all your disease resected and you have a very, very good prognostic outlook, then you need to think about these things. Proper imaging, and if you're working with a good team, if you have good doctors, this is something you're not going to have to worry about. Because they're going to be using scans properly, they're going to be spacing them out at proper intervals, and they're going to be aware of, not using these things too often, both from a cost analysis and from radiation exposure. So the main issue is the exam needed and is a proper exam done. And if you're working with a good team, that's not going to be a concern. But if you do have any concerns, you can ask your oncologist. They're not going to want to talk about it. They're going to, but they probably won't. But they can refer you on to your radiologist or radiation oncologist. All facilities are going to have medical physicists and radiation safety officers who should meet with you and have a discussion with you and address your concerns about that. So I know this was a lot to cover. I hope I didn't move too fast. I was a tendency to talk too fast when I do presentations. So, if there's any questions, feel free to track me down or ask me up here. That was it. Thank you. And thank you to NCAN again.